I would like now to present you some other information on a more philosophical level, if I may call it like this. And this is the very important topic of what are the criteria for additions in synthesis, okay? In order to do this, we will separate two chapters. First is about clinical additions, okay? And the clinical additions, there are three criteria, and there are especially, they need to be adapted to two situations, whether acute or chronic. First of all, and this is a suggestion I have written and made in the first printed version of synthesis in 1994 or 95, I believe, in the blueprint, and I believe it still stands the test of time, this idea, that additions, if they come into the repertory, we should consider whether they are based on a clear-cut case. And what is meant by a clear-cut case? That is a case that did not receive another remedy, that did not improve because of another therapy, and that did not improve because of other circumstances. Like if a patient comes back and says, I feel much less depressed, I feel much more energy, my appetite has returned, but at the same time, 1 month ago, they fell in love with a friend, it's not a clear-cut case. Circumstances may explain the improvement. So please make additions if there is only one remedy, no other therapy, and you verified that no other circumstances are the reason for the improvement. Now the second criteria is that the case should be spectacular, not like improvement, but spectacular improvement. In an acute case, it means for me that one remedy is given for the cystitis and there is an improvement and improvement, and the case is done. So one remedy pushes the patient from the problem they have, the acute problem they have, onto the improvement. Full stop, done. One remedy, done. No other therapy needed, no other homeopathic remedy even needed. This is a spectacular acute case, okay? In a chronic case, it's a little bit different. The nicest way that the remedy is responsible, or to know that the remedy is responsible for the improvement and not circumstances, placebo effect, etc. A nice conversation, as some of our enemies say, that the homeopathic improvement is due to nice conversations, long conversations, is in fact the repetition of the dose. Okay? So you have a chronic case, you give natrium silicata one time, you have a repetition. After a few weeks, few months, the patient is again showing the original symptoms. We repeat the dose and again the improvement takes place. And like this, we built a famous curve that the patient overall has these steps of improvement each time after repeating the dose of the same remedy. This is a very spectacular improvement of a chronic case, and it clearly shows that every now and then that improvement is linked to giving the remedy and not to whatever external circumstances. Then the third aspect to say this case can serve for additions is that it needs to be have been tested by time. And time for an acute case is speed. We cannot say that we use this acute case as a fantastic cure case on which we base our additions, etc., what we use for teaching even, if the onset of the improvement wasn't fast. If you have someone with a flu and that patient improves after 5 days with one remedy, shall we say it's fantastic? It's a fantastic and possibly useful acute case. It may be, but it's not the type of case we would like to use and to say, listen, this case is suggesting that I make additions in synthesis because of it. And because the flu would have been better maybe within 3-5 days anyway. So we need to see an onset of improvement within 24, even 12 hours. And you know pretty well that we do have these acute cases where people say that the improvement starts within an hour after taking the dose or even faster. So an acute case we use for additions in synthesis should start improving within a short time, 24-12 hours, should cure the case throughout, and there should be no other interferences. In the chronic case, it's a little bit the reverse. The test of time is not the speed, but the duration. And some people feel only safe submitting a chronic case to make additions or for publication in a journal when the years have passed by. Okay? So these are the basically 3 ideas that I still suggest to consider when you want to know, shall I use this case or not to make additions into synthesis. The second chapter is about proving additions. And in the proving, there is this list of 7 criteria that I have collected from reviewing all the literature, including, I don't remember the Indian author, was it Tariq something? Anyway, there is an Indian author also. Several authors, Jeremy Sher, the American group, many people have given many ideas. Why should we enter certain symptoms of approving into the repertory or not? And if you read all these ideas, it's all about some kind of probability. How probable is it that this symptom in this proving is important and must be added and made available to the community? We have these 7 criteria, and if 1 or 2, let's say the more criteria are present, the higher the probability and the importance to make the addition of this proving symptom to the repertory. So when the symptom in the proving has been frequently present, intensively present, or peculiar, it's more important to add it. Times is like almost a negative. Don't put too many times in the repertory because of a proving headache appearing at 11 a.m. No, it must be put when it's repeated, okay? And when there is the symptom, like pain in the left temple, stitching in the left temple, is present in more than one prover, more than one potency, it increases the probability. If the stitching is present in more than one localization, it decreases the probability that the stitching is an important sensation. 6 and 7, in tune with the totality of the proving or the inner conviction of the prover or the proving director, okay? I will not go into detail, but please look at this slide. Those involved with provings, I believe, will recognize these ideas, okay? Now, the most important issue for additions is almost about the degrees. And when we go to Kent in lecture 33, he sets out the criteria of provings and cures. And basically, the more provings and cures we have, the higher the degree in the repertory should be. And if we meticulously evaluate all the phrases where Kent defines the degrees of the repertories, we see that the frequency levels that he says can be divided into 5. The symptom appears never, once, a few times, often, or even very often in a proving or in a clinical case records. Now, if we translate the definitions of Kent's degrees into this table, we see here that Kent was saying if the symptom appeared once in a proving, and it has not yet been confirmed or confirmed once or confirmed a few times, it can be entered in the repertory. Okay, so a proving symptom without clinical information can be entered in the repertory. On the other hand, he says if a symptom has not appeared in a proving but was frequently, often confirmed in the clinic, it can be entered in the repertory too. And then second degree is defined as often in provings and often in the clinic. Third degree, very often in the provings and very often in the clinic. Now, what is the problem with these definitions? As clearly shown from this table, basically we have 25 possibilities, and there are only, 6 possibilities defined. So which degree to use in all these other possibilities? Okay. Now, a lot of discussion has taken place about the degree, and this is the last slide that I will show you, and has led me to the idea that we must not only have the presence of symptoms improving as a criterion, not only the confirmation of the symptom in the clinic, but also who made the proving the cure of the patient, or rather how many. We have 3 criteria. If we look at all the discussions, and from the table I will show you in a minute, you will understand. So how or how many people, who or how many people made a cure once, a few times, often or very often. I just use the same terms of Kent with one specification. If it's about how many people, there can be a one person who did it once or a few times. Then we will symbolize it with a plus. One person cured the symptom a few times, meaning several patients, okay? And then we can have several persons who use this remedy and observed it cured a certain symptom. We have 2 pluses. And then one step, the highest level of confirmation, would be that different teams observe the same improvement or the same proving symptoms, if we speak about 2 or 3 provings of the same remedy. Okay? Now, if we consider that these are the criteria, when we analyze all the discussions and the articles about degrees and adding or not, then we come to this table, where we have at the left the 4 degrees. And if I may ask you to first read the upper row, there is one person. Of course, it has to be at least one person who has observed either one cure or one proving with the symptom. And then we can enter it in the first degree. Okay. Now, I'll jump, for the sake of logic and didactics, I jump to the last line. What is the highest level of confirmation we can have, corresponding to the highest degree, being degree 4, is when many people of different teams have observed many times, very often in clinical cures, that the symptom that was mentioned in the provings a few times, a number of times, or many times, cured that symptom. Okay, this is the maximum. 3 stars all over. Now, in between, we have to reflect a little bit what to put. And the suggestion is this, that the symptom can be in the 2nd degree when there is one time or a few times confirmation in the clinic. And when it is one time or a few times present in the proving. I left the 0 here because I believe we can have situations where a symptom in the clinic is cured without it being present in the proving. Okay? And then who will confirm this? One person, possibly. Yes. Proving and clinic. Why not? The plus means a few persons, or even several persons, many persons of the same team. But as long as we stay in the same team, we don't go to degree 3. To go to degree 3, we need to have different persons of different teams. This is one of the key ideas. And we will adapt synthesis and change the provings and degrees to this philosophy that I'm explaining now quite extensively. A 3rd degree, I believe, should only appear when the remedy was cured or proved by different teams. Why? Because we get submitted these urgent requests. Someone made a proving and had a cure, and more than one cure, and then someone else had a cure. Yes, it's totally confirmed in the clinic. It has to be 3rd degree, maybe 4th degree. It's very important, the symptom for this remedy, and we have it in the proving, and we have many cures, but it's all the same team, you see. So we cannot how shall I say, it's almost bring our repertory in a certain direction by too many 3 degrees, and sure, 4th degree should be the consequence, the result of a team effort. Okay, and this is why there is only 2's here and a 3 here for the 3rd degree. Okay, so I leave this for your reflection. You can contact me on all these ideas.